Here we go. Mike 3-3.
Managers meeting today at 1:01 p.m. All right. And then we will come forward with Leanne.
Beautiful May afternoon, we lift our hearts to you. We thank you for all we've been given, especially the opportunity to work together as we focus on our true north, our patients. We ask that you grant us unity, that you sustain our vision, that you inspire our hearts as we continue focusing on community and committing to excellence. Let us feel joy knowing that each of us is called to your good purposes in this place. In your holy name we pray. Amen.
Do I pledge?
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, thank you. Do we have any citizens wishing to address the board? All right, there being no citizen. The next on the agenda is approval of the minutes. Are there any corrections to the minutes?
Second.
Well, okay.
Third place.
Wow. I have no idea who motioned it. All right. Are y'all doing the fingers today? So I've got to look up. Okay. It was motioned by Steve, seconded by Ralph. Okay. All those in favor of approving the minutes signify by saying aye. And those disapproved by nay. Motion carries unanimous. This being Hospital Week, I want to have a little say and do a special thanks to all of the staff. Number one, I thank you for selecting to work for JPS. Number two, for the continuous wonderful job that all of you do to help the organization move forward. Even in trying times, we continue to get our certifications and just be an outstanding organization. So I want you to, don't say it often enough, but I thank you for all you do to help the citizens of Tarrant County. All right?
You're here.
That's for the whole team, not just you in this room, but all of the team members. Okay, thanks. Okay. All right, okay. Dr. Duncan?
Turn this on. Somebody keeps turning me off. Thank you, Madam Chair, for that. Thank you to the hospital staff. Just a little bit of an update today. Our community remains in low COVID transmission, which is good.
Great.
We had, last week, actually had 0 patients in the hospital with a diagnosis of COVID, which was great, and we held that for about 2 days. We now have inched up and we remain in the single digits and kind of holding there. So we'll continue to monitor as we start to see nationally an uptick in COVID cases that are requiring hospitalization, but right now we remain in the single digit. And of course, we are encouraging our communities to use the tools that are out there, which is vaccination. And so we do have the telephone numbers posted for our communities to be able to call and to receive those vaccines and boosters, because we do know that that is probably the most powerful tool for all of us. A little bit of team updates. I think many of you have had an opportunity to meet Bill Masterton, who is our COO. And since Bill has joined, I've actually had opportunity to get some sleep at night. So welcome, Bill. It's been great. He's been here for 8 days now, has already hit the ground running. So truly appreciate Bill. I do also want to update the board that Diana Broder, who's our VP of Communications, has decided to go home and spend time with her family. So she will have her last day here at JPS on June 3rd. And so we will begin the search for a new VP of Communication and Marketing, and I will continue to update you on that. Also, want to give you an update. We had the opportunity to hear from our consultant, Canaries, who is doing some of our DEI work, which is diversity, equity, and inclusion work. Wanted to give you some update that they continue to meet with teams, and also, more importantly, to start to pull some of our data and look at some of our policies. They are, just to remind the board, the consultant that we're using to internally look at our diversity, equity, and inclusion program and start to help us build that internally for our staff and for our physicians. We continue to partner with Case Strategies on the vendor and the contract work that goes on outside in the community to ensure that we have good diversity spend here at JPS and that we are inclusive with our vendors. So just wanted to give an update on that. Also, in our journey to excellence, in our culture of excellence, we've undergone a recertification with our acute myocardial infarction program. We did quite well with that with no findings, so we continue to pursue PI projects. Dorothy, I know that was a question that you had as to the project, but these are all process improvement projects that go on across the hospital, and we have been recertified through Joint Commission for that program. The other one, which was a new certification for us, is our blood management program. And we actually received the highest level of certification for that. That was the first time we went for certification and received the highest certification as far as our blood management program. It's blood management program, yes. So, and that also is through Joint Commission. Those last two certifications are on-site visits, so they have come back to on-site visits, and so it really says a lot about the teams that they were able to visit and the hospital itself. So great work by the team.
That's excellent.
Yes.
Last week we had Nurses Week, and that was a lot of fun. I tried to stay out of pictures so they would not follow me, but the nurses, it was great to have our staff be able to come together, still safely together, but to come together to see each other. We did some ice cream rounding on the floors at nighttime. That was well received by the team. So I want to thank our nurse leadership and our staff that also supports our nurses. And then, as Dorothy said, we are finishing up with National Hospital Week. I don't know if this is a little fact that I found out, but actually the first National Hospital Week was in 1921, following the Spanish flu. And it was to help connect the community with caregivers. It was actually the community that was reaching out and saying, how might we help you? And that's kind of how National Hospital Week started. So just a little fact. With that said, I'd like to thank you, the board, for thanking our team. And if we can run the video that was put together.
To all of the staff, employees, physicians, and everyone, I am so grateful to be a part of this wonderful team. Thank you for all the work that you do every day and do it with such style and comfort, and it's such a wonderful community support group. So I want to say to you, thank you for all you do every day.
Hello, JPS team members. I'd like to wish everyone a great hospital week, and thank you so much for all that you do.
Thank you, thank you, thank you. And there aren't enough thank yous to go around for all of the folks that take care of our patients in one way or another.
Thank you, JPS staff, team, and everyone in between for all the hard work that you do throughout the year, and we appreciate your dedication and commitment to the people of Tarrant County.
Thank you all, each and every one of you, for what you do, what you continue to do, and what you've done over the last 2 years. We're all grateful for you, and we're proud of you, and we're happy to be a part of the team with you.
Thank you for the JPS staff for all that you do. Have a great hospital week, and remember that everything you do is resonating through this community in so many ways, through so many people. We're very proud of what you do.
We really appreciate everything that you guys do every day for our patient, for our hospital, and for our community. Happy Hospital Week.
Happy Hospital Week. Thank you all for everything you do and everything you do for our patients and our community. It couldn't happen without you.
I'm excited this day to express my appreciation to those committed workers who have given their all morning, noon, and night, commitment to those who are in need. We celebrate you all, the workers of our hospital and every hospital in this country. We thank you for your commitment and your endeavor to do the best you can, all you can, while you can. Thank you.
So on behalf of the JPS staff, JPS board, I'd really like to thank you for all the support that you give to JPS. We could not do it without your support, so thank you.
Wait a minute. Well, I was going to ask if we could get one of those makeup artists to be on standby for now, help me with my hair.
So we will add it to the budget, and you guys remember that, because strategically, it's going to have to be a line. I know Reverend Emerson is going to remind me, how does this fit into our strategy? So we will try to figure that out. We do have some T-shirts for you. Tomorrow's T-shirt Friday for us here at JPS. I believe it may be one of our first T-shirt Fridays.
I thought you said seizure Friday.
T-shirts. And so, Dorothy, can you hold it up there? Yeah.
Excellent.
Okay. Thank you, Madam Chair. And that's all I have for an update.
All right.
Reverend Emerson.
Nurses Week. Does the hospital still honor like the top nurses and give out the awards for it?
Yeah.
Yes, we do. As part of that week, it's those awards are given out. And of course, we honored the top nurse, which is Ms. Debose.
The reason I ask is because for me, it was just one of the highlights of being on the board. And I had never, ever missed one since I've been on the board.
Oh, is that right?
No, but I guess you're not doing them in the auditorium anymore with the COVID, so. But I've not, I didn't get to see it. I wasn't there this year, so I don't.
Yeah, they actually did it off-site this year. Yeah, very small setting at one of the restaurants.
Okay.
Yeah, of those who were given those awards, but.
On the internet of the nursing.
Okay. It was just really, it's just a touching time, so. I
So they
really
used to
enjoyed it.
have a big deal in the auditorium. We'd have one of the board to speak. And
Yeah, I think I
all of
was,
the
yeah.
Great 100 nurses would be recognized. It's a touching program.
Yeah, it
But
is. It is.
I was very, very happy with how they recognized the top nurse. They got flowers there. They were beautiful, too. They came in, it was really a surprise. Nice.
I will give that recommendation back to nursing.
Okay.
Thank you.
All right. Thank you, Dr. Duncan, for that great report. All right, Dr. Miles?
Thank you, Madam Chair. The medical staff continues its delineation of privilege project, and so we have for your review today, there are actually 6 new privilege forms in your packet. However, I'm going to ask that we remove number 1 from the packet after further review at the MEC level and with the Department of Surgery chair. It was determined that we'd like a little bit more time with the first one, which is the APP Surgical Services Clinical Privilege Form. The rest will be submitted for your review. It's number 2 through 5. They're under tab 3 and begin on page 16 behind tab 3. The first one is the Gastroenterology Form. The major change to this form is reducing the number of encounters required for initial appointment and reappointment. They were rather excessive compared to national benchmarks, so they were reduced roughly from 400 to 100 and 800 to 200. And then if you jump back to page 19, it's the same issue there. We've reduced the number of encounters required to demonstrate competency in gastroenterology. On page 20, this is the Certified Nurse Midwife Clinical Privilege Form, and this has quite a few additions to it, as you can see with all the yellow highlights. The yellow highlights represent additions. Dr. Sangha was extremely involved in the development of this privilege form. We appreciate her expertise. Really what we're doing here for the midwives is clearly listing out and delineating what they can do. And that's important because by listing what they can do, we're also saying what they cannot do. And we felt that we really did need to clean up our form for those reasons, and that is the nurse midwife form. On page 26 is the Hematology Oncology Form. This again is an issue about adding in numerical benchmarks. The Joint Commission wants to see that we have numerical benchmarks to establish competency. The form previously had none, so you can see where we've added them in with the yellow highlight. Also, we removed the restriction greater than 18 years of age so that our hematologists, oncologists could consult on and see patients who are less than 18 years of age. And then on page 29, dermatology, on page 29 is a little bit of cleanup. On page 30 is an addition of a new privilege called procedural dermatology. Procedural dermatology is a dermatologist that has fellowship training to do more complex procedures, and that is all new additions in the yellow highlights to add in procedural dermatology. And then finally, I believe page 32 is our last delineation of privilege form for radiation oncology. And this was really just adding in some additional language to further define what represents a core privilege. I'm happy to entertain any questions from the group if you have any further questions on these 5 forms submitted for approval.
I have one question on the nurse midwife.
Yes, ma'am.
I'm on page 20, well, really, I'm on the back of that, some of the items that they removed. And I just wanted to know, as a part of this, did you have a midwife that was a part of this process of reviewing and updating this? Because they have a school, and I'm wondering if we have taken some stuff out, that if we want to bring midwives here, that is covered. That's my question.
I'm actually going to ask Dr. Sangha to come up and speak to that. She is the expert in this area, and I will defer to what she has to say, please.
Good afternoon, everyone. Madam Chair. What was being done in our surrounding hospitals in the state of Texas, and we also reviewed information and privileges that are used nationally in the country, and those were then used to look at these forms. What we specifically removed was privileges to do operative vaginal deliveries and 4th-degree lacerations. That is a very complex procedure that should not be done without supervision of a physician.
And my question was, if you would decide to, I know we were training them, what your changes, it will allow us to still train nurse midwifery.
Absolutely, okay. Yes, because that's kind of beyond the scope of midwifery practice nationally as well.
All right, thank you.
Thank you.
Is that a program you drop?
Thank you, Dr. Sanga.
Well, you know, Kathleen Donaldson had been here forever, and we always trained, and so I don't think we are not planning on bringing that program back. And so I just wanted to make sure that as midwife, we come back to train, that we would be able to meet the school's needs too. Okay.
So just to be clear on this topic, Madam Chair, the privileges that were moved on page 24 have been moved to the core list. So they are not excluded from the privilege, they've just been moved into core. The ones on page 25, the three on page 25 were removed altogether because they are felt to be outside the scope of a nurse midwife.
Okay, I saw that. And this question was, I know as we train, they have some programs that you must meet. So I just wanted to make sure that as midwifery come back, if we are going to continue that program, that they would be able to train here and do all the things that they need to do as part of their curriculum.
Yes.
Okay. All right. Thank you.
You're welcome.
Yes, Roger.
Dr. Miles, I just want to confirm that when some of these cases, you know, went to 100 from 800, and that's based on compiling and getting averages from everybody else around us?
Yes, we looked at other institutions of like size, like patient acuity, and also level 1 trauma centers when we make these decisions. So they're not arbitrary that, let's just pick 100. They're not arbitrary. They're definitely compared against other institutions who are similar scope and size to us. There's a lot of variation across the nation in terms of these numbers, but clearly 800 is a huge outlier.
Right, yeah.
And you know, the thing about 800 that you have to remember is that if I require you, Dr. Fisher, to have 800 widgets before you can practice at JPS, you may actually have a claim to say that I'm economically credentialing you and I'm prohibiting you from getting privileges here. So there's a sweet spot in these privileges to say we need enough numbers to ensure that you are competent to do the skill that you've applied for, but that we're not preventing you from coming here because it's an absurdly high number.
Sure. Thank you. Did you hear that, Steve? Doctor?
Yeah. And I would hope as we look at those numbers that we make sure that with some of the leapfrog information, they have so many procedures that different specialty have to do that we will meet those too.
Yes, thank you for that, because it's very important that we keep that in mind, that we do not put any of our certifications at risk relative to our procedures. So we are crosswalking that as well.
Okay, thank you.
Yes.
All right. Are there any other questions? All right. Can we take this all at once? Okay, I will entertain a motion to approve the clinical privilege for 2 through 6.
Recommend approval.
Okay, Chuck.
Second.
Second by Zim. There being no further discussion, all those in favor signify by aye. Aye. And those opposed by nay. Motion carries unanimously. Okay, Dr. Becker, I think you're up next.
Thank you, Madam Chair. Good afternoon.
Hello.
And thank you for acknowledging all the team members here. It's the first time I had a chance to see the video, so appreciate everybody's faces and support. As usual, I will start with clinical. I do have one adjustment I will make on this. You have the more abbreviated scorecard. I promised you that we would start reducing the number of parameters that we're tracking. And you have what represents performance through the first quarter of this calendar year. I will note that while it says green for open access scheduling, that now should be yellow. And I have to do a lot of things pursuant indeed in conversation with Dr. Duncan to make sure it doesn't go red. So we're doing some of those things, and I'll mention that. But overall, I think performance is solid in these very core areas. I do want to call out Dr. Sangha, who is behind me. When we look at the individual departments, she is, for the month of March, was at 80% attainment of her list of really important measures. So kudos to her department. This is how we're performing, and as usual, we'll bring that to you. Then in my brief summary of what's going on, I will go through the usual categories. First, I want to highlight a couple things that are more associated with inpatient, because it is hospital week. Dr. Compati, our cardiovascular surgeon, has done a tremendous job actually shouldering a burden on his own recently because the gentleman who's normally partnered with him is out for a period of time. He has also implemented significant improvements in quality of care related to diabetic management for patients who have to undergo bypass surgery, as well as taking them off the ventilator in a different way. And what it has led to has been, in a short period of time, a demonstrated improvement in outcomes. And it's through just individual, thoughtful effort, working with the teams, whether it's anesthesia or nursing, and or the residents, to make certain this stuff happens. Second, I did want to bring to you that I have met several times with the hospital medicine group, both Sound and our teaching hospitalists. You have picked up on a couple different aspects of performance recently. So they have a charge, which I will be meeting with them again this upcoming week, to decrease length of stay by a day, to decrease observation stays by 75%, and to align our patients with an outpatient appointment with one of our physicians within 5 business days after discharge. The goal for this is improve patient care. When patients sit in the hospital and they don't need to be here, they are exposed to the hospital. And that is not always associated with good outcomes. Number 2, efficiency, which actually helps across the board with regards to staffing, with regards to appropriate redistribution of attention and care to other patients. And third, to make certain in the transition of care process, which our teams have done very well, we actually get that extra piece in place in working with the physicians so that the medication pieces and the appropriate follow-ups that need to happen in the outpatient setting are undertaken much more readily. This will be a lot of work, but yes, sir.
Yeah.
It needs to be done.
I don't disagree.
We need to do it. So we're gonna put it out there and we're gonna do it. Okay. Now that I got a lot of work on our hands, I'm not taking it back. We need to do it.
You think there's much?
There'll be some, but I now realize that Dr. Fisher and Dr. Montgomery have some really important thoughts on things, so we'll be okay. We'll get some. But I think this is doable, and it puts the physicians in a responsible role for helping lead and collaborate and partner with the multiple different teams that we need to have involved in this. So, we did have and I mentioned this to several of you, we had a retreat for our physician leadership around the theme of belonging, end of April. Carla Cueva actually helped facilitate it. We were fortunate enough to get an interaction and a description from the Canaries group of what they were going to be doing for the organization with our physician leaders that day. And it set the stage for what will be something that I will mention a little later on that they will have as part of their work in June. I did want to let you know we have several different things happening within the acclaimed leadership positions. As I've discussed with Dr. Duncan and Daphne, we did not mean to be in front of what the CEO was doing, and I apologize, but we actually had posted a position for someone to help from a policy standpoint. We have hired a young lady by the name of Claudia Tijerina. She is a lawyer by her degree. She's been working at HHSC in a variety of positions, most frequently as a senior policy advisor in the Chief Program and Services Office. And I think she'll be very helpful for us defining certain aspects related to policy, in particular to the physician group. And I have certainly made it known that as individuals feel she can be helpful to the entirety of the health system, absolutely. I think she brings a lot of experience there and can be, I think, very beneficial with her insights. She's a lawyer. She trained in sports law, actually at Marquette University. She's originally from Texas. And we had a little conversation about sports law. I told her when she spoke with Daphne that they would enjoy that conversation.
Dr. Becker, she's coming in for that position, but not as a lawyer, right?
Correct.
Okay.
Yes.
I just wanted to make sure that we understood that
Yes.
was, okay. All right.
We have 2 individuals who are finalists for finance lead role within Acclaim. One interviewed yesterday, one will interview next week. I've appreciated Sharon and her team being involved, as well as the other Acclaim leaders in evaluating and meeting those individuals. And then, as some of you know, Diana Prachel transitioned out of the organization very recently. Diana had done a tremendous job, obviously, in getting Acclaim going. We will be interviewing 3 individuals as COO candidates for Acclaim very early June, and hope one of those is interested and meets all the requirements.
Dr. Becker,
Yes.
that position changed to report to you, or is it still that dotted thing? No, my question is, I think at one time the COO position report to kind of dotted line somewhere else. Is that going to be
The
straight line to
COO
you?
position will report to the president of Acclaim.
Right, okay, so directly.
Yeah.
Good, thank you.
Let me shift to the next item. Just briefly, a few things about what I am seeing on behalf of the practice at the moment, and therefore on behalf of a lot of activity. We do have a significant increase in our ambulatory activity overall year to year on our comps. I have noted to Dr. Duncan, I do have some concerns that the proportion of new patients as a total component of our overall ambulatory activity is actually down 11% relative to last year. And so we're looking at what we need to do to considerably boost that. New patients are obviously critical to the organization. In that regard, and the reason why I'm going to change what I said was yellow and make certain it's not red in the open access, we've met with the pediatricians that we have in the organization, and we will be looking to do open access in the morning across the entirety of the network from 7:30 to 9 a.m. It is a time when individuals often do need to do some things for their children. That frees that time up to make certain that we're able to accommodate what would be classically acute/urgent care for pediatric problems. Second, the medicine specialty clinics, which have over the most recent 2 years not been open as frequently as they might need to be, are going to open up 5 days a week. And just please reserve your questions and comments till I'm done. We will be short of essentially mandating open schedules for individuals through the entirety of the day. Many of the physicians, for some reasons, have adjusted schedules, et cetera, and the templates are relatively consistent. So we have a significant backlog as well as a need to see patients in med specialty. In fact, many individuals want to see that specialist maybe in lieu of even a primary care physician. We know we have services we need to provide, so that access piece will be opening up. I envision that will titrate up over the summer into the fall as we both open everything up and we do work with existing PTO time that has already been scheduled. So. I am working on, and I've been back and forth with Rory on a number of different items. I have discussed this briefly with Sharon recently, looking at why our inpatient surgical volume is not ticking up as much as we would like. There are probably multiple factors, and I can't point to one in particular that is the sole cause, but we're working through a number of different efforts there and want to make certain that patients receive the necessary care that they should have. And so I will be working with the finance team and others to make certain we rejuvenate that. Finally, I did want to note for you, I have been in discussions with a potential partner about opening up some additional access in the community through a different urgent care platform to continue to find ways to provide access for patients no matter what. That is in its early stages. I've discussed it with Dr. Duncan, and after I review it more in depth with her and the team, we'll bring it back at the appropriate time for you to review. I do know that we want to see more patients and make certain they have easier access closer to where they live throughout the entirety of the county, and we want to be able to have that platform for them to do so.
Can I ask a question about your medicine clinic and opening in 5 days? Is that just going to be on campus, or are they in the community, or is it just limited to this campus?
Thank you for waiting on that question. So on the medicine specialty, I think we're going to look at this in 2 stages. First of all, some of our specialists do work in 1 or 2 of our other medical homes. In particular, we do have a footprint for cardiology, neurology, and pulmonary, both at our Southeast Medical Home and our Northeast Medical Home. What I'd like to see on this campus is that we go 5 days a week to 5:30. I'd like us to do a little bit more than that, but let's start with that.
Okay.
Number 1. Number 2, I have had conversations and have begun thinking about the possibility of setting up some of our medical specialists actually in some of our medical home sites as a permanent location for them, so they are not rotating, but we are using the demographic and zip code data that we have of disease processes and actually put specialists into certain clinic sites where they're more likely to be full, not only all the time with patients, but be able to provide that relevant expertise. In that context, I can envision nephrology, cardiology, potentially pulmonary being more top of mind for those. And we're looking to probably stage that deployment over the next 6 months.
Thank you.
Yep. Last point, I did want to note, we had embarked on an exercise with a group of students at TCU in the Neely School of Business to help us look at the core capabilities we need to do a number of different things if we were to take on risk, if we were to become ACO-like. We had a number of our team members who were interviewed as part of focus groups. They completed that capability map. It's a nice grid that shows, based on a heat map, where we have good stuff and where we have stuff that we have gaps. That can help many teams with a roadmap of what we need to build or obtain in order to be successful there. I was happy with it because we got a very high-level consulting engagement tool, and we got it for the price of a capstone project from students.
All right.
I do want to point out a few other things. The compensation team here, and I want to call out Shannon Spangler, identified a pretty significant error from the Guidehouse data. I have communicated that error to the physicians. We had a town hall in addition to the usual ones, and we are going through the process of the shadow period. I will be bringing to both Sharon and Dr. Duncan what the compensation plan looks like, and then with their approval, we'll then bring it to you, and then with your approval, I will go to the physicians and go for the vote. But I want to do it in that order if you're okay with it. We are making progress on our work streams. I mentioned those last time. All 8 are still flying and moving. And in mid to late June, we will do an objectives and key results exercise. In a claim, as you recall last time, we have a big 4. With that big 4, we roll up to the strategic plan. We will define more core objectives for those big 4 and have the clinical departments define their objectives and key results. We will ask Lauren and her team to be present because these will inform the goals for next year for a claim in the physicians. Lastly, we continue to have a positive budget variance. We were about $600,000 to the positive a positive budget variance, I better not say to the positive budget variance this past month. I think that puts us at about a $4 million positive budget variance for the year. We'll continue to address that. We are looking at partnering both for good care, and I'm going to emphasize that, as well as the opportunities that we may not be accessing today, and I believe they're significant, for services that our Medicare beneficiaries and our Medicare Advantage patients actually can access. These include additional services, whether someone's transitioning out of the hospital or coordinating their care through a particular way, and/or additional quality and service and care gap closures. Acknowledging we want to do that, and we want to do that as an organization, there are partners who will do this with us in various ways, and I will be bringing back through the acclaim process and then to you, likely a contract for that. This is an important opportunity to deliver better care, and it is an important, I'm looking at DT because he knows this, it's also an important opportunity where we have significant revenue that we are not capturing today. And as I bring to you ultimately a compensation plan, I want to also bring it to you with the anticipated capture of additional revenue as well.
Okay.
So that concludes my report. Thank you.
Any questions?
Dr. Becker, we're pretty far along on the compensation modeling. So what's the nature of the error from Guidehouse? I mean, it's not like we just started that project, so.
That is correct. So the error, the compensation model was created to deliver something called base plus. So there's a base compensation, and there are two pieces on top of that. One is related to being more productive beyond that base threshold, and one is related to quality performance. In the plus part that's productivity, we had initially discussed giving more value to each of the units of work than just the normal 100% value as an extra incentive. That would be, instead of paying 100% for an RVU, we would pay 110% for those RVUs where somebody was doing more beyond the base. The mistake was that they did not include above 100%. And so that had a significant financial impact in the modeling. I will say that probably was a very good thing it was caught, and it helps make my presentation to Sharon and Dr. Duncan a little easier, because I think if I came in with the first, there would be a problem. Second, I had communicated that we were going to potentially include this, so that's why I went back out to all of the physicians and said, we found a mistake, this is the mistake, this is what it means to you, this is the data you're still going to see. We will still continue in the shadow process. But I wanted you to know that's what it was, and it was not insignificant.
Thank you.
Any other questions? Thank you, Dr. Becker.
A lot of good work.
Yes, very good work. Okay. Now we will have the reports from the committees, and we'll start out with Finance, and DT will be doing the report for Trent.
I'm going to try to do my best since I was not at the April 28th Finance Committee. I have a commitment out of
Go
state.
ahead, I'll correct you.
This is when I speak very low so she can't hear me. Anyway, March continues to do a good month for us. The result was in operating positive operating margin for the hospital. The program, the CHIRP program that we've been waiting for, was approved by CMS in March, and we were able to recognize $9.5 million to date for that program. For financial metrics, I think our cash on hand continue to do well. We are over 400 days in AR. In cash on hand. And from a net AR perspective, the team's been continue to make some improvement there, and the AR days is coming down. So it's one of the trend is looking good. JPS connection enrollment continue to flat at about 3,800 for the enrollment. And I'm pretty sure our finance team is looking at, and what we're trying to figure out is how much work has been put into place the flow of other programs that come into play when you have a patient that have some other needs for financial and all that stuff. So I think in the next few meetings, we may be able to highlight some of that stuff and kind of give us an education of how much work is being done and, and when we can recognize revenue and all that stuff from the patient enrollment and everything else. From a claim's been, the budget's been favorable also as well, thanks to the leadership of Dr. Becker. I think that area we continue to find interesting engineering and tighten up the process and all that stuff. Thank you, Dr. Becker, for doing all that stuff for us. I think the activity has been increased because of elective surgery that we have, and also face-to-face clinical visits continue to be strong for our revenue. But I think we still have some notable several provider positions currently still vacant, so a lot of recruiting going on in that area also as well. And contracts, you will see about 7 contracts in here that are presented for approval on the consent agenda. And I'm happy to say none of them require exemption to bid. So that's our report, madam.
Well, thank you, DT. And I will do the planning committee for Trent, and we had our meeting and the committee approved to move forward posting of the RFQ for the data center consultant and the landscape architect and the acoustic architect. We recommended approval to move forward with the Alliance G Technical Group for GEO Tech Engineer Consultant. We also recommend approve the recommendation of the award to Jacobs for the Cogent Consultant. And the committee approved the recommendation of the award to the Cogent Architects for the AE standard. And we approved the recommendation to the Commissioner's Court for J.E. Dunn, Beck, and Porster as a top finalist for the new parking garage design, okay? And we got an excellent report from Angie showing us the capital equipment, capital projects that we were working on. And she always do a fine job of telling us where they are and what we have left. So she completed a lot of those. That's what I have. Okay, anybody have any questions of me for Trent? I'll call him and ask him. All right. We just had quality and the Medical Horizon Committee. And so what we will do is move them to our next because they have some recommendations. Did you have? I have no action. You have no action item. Did you want to give your report today? Okay, because I was going to move those to the next month if you had action items so they would be with the deal. But you just have a verbal report, right? And you got it. Super quick. All right. Karen's burning a hole. Okay, so we'll do the Medical Horizon Committee. Thank you, Steve.
I'll just do a real quick update. We had a great meeting this Monday. Dr. Elliott gave us a wonderful overview of the academic and research affairs. 3 items I just wanted to highlight for everyone's interest. Some cool things we're doing in this community. We welcomed 11th and 12th grade students from O.D. Wyatt's High School Health Sciences program for our first JPS Future Healthcare Heroes event. Where different JPS team members spoke to students regarding their own educational and healthcare career paths. So it's a great kind of way to start getting young kids who may not have examples in their lives of healthcare, or they may think of it only in terms of nurses and doctors. There are many things, many career paths within healthcare that they might pursue. Another really great thing that I was particularly interested in was we did our 2022 match day. And this is where medical students and residents and fellows from medical schools pick our interview with JPS, and we interview them to pick where they're going to do their residency programs. And the match day occurred, and the whole process was fascinating. I'd never heard that. So we've gone through that process. And then finally on the research and innovation department, something I wanted to highlight is that they're doing a current patient care project related to opioid use screening and treatment interventions, which is obviously highly pertinent these days. So a lot of great things going on down there.
Yeah, I thought so too, and it's real good we're having that committee again and all the great stuff. And I looked around the room when you was talking about the match, the doctors was going, ew, they know about it, but the rest of us don't. So thank you for going through it. They were just going like this, oh, well. But it's new for us, so thank you, Steve. All right. If no one have any more questions of.
I have a request.
All right.
I wanted to make an update on where JPS may be getting funding from the opioid settlements that are going on, if anything's been settled. There's been some stuff in the newspaper, just we haven't talked about it in quite a while.
Right.
If we may. I mean, you don't need to do it now. Just
No, I'll discuss it during the litigation update.
okay, thank you.
All right. Any other comments? All right, thank you, Steve. Good report. Next, we will have the district's maternal program plan and resolution. Dr. Zanga.
Good afternoon again. So the actual match process, the person who developed the process was an economist who won the Nobel Prize for Economics, was basically more about marketing and matching people to their choices with the products were available. So it's a very complex process. So thanks for explaining that very simply. It is a very challenging process. Sometimes the people who are applying for it itself don't understand it as well. Yes, it is. So thank you again, Madam Chairman and esteemed board members. I'm coming to you today as Chair of Women's Health at JPS to ask for your continued support and approval of our maternal program plan. You all had approved it earlier on in 2020. We had our survey for maternal levels of care in September of 2020, and we were very pleased to get a designation of level 4, which is the highest level of acuity of maternal care that is provided in the state of Texas. We are up for our resurvey on May 17th and 18th, which is next week, and we, as part of the maternal levels of care designation, the mandate requires that the facilities governing body approves the program plan, which we have included. It's a very comprehensive plan that outlines what we are doing currently, how we've moved the needle in maternal care, and how we're partnering with different quality initiatives in the state of Texas. The maternal levels of care designation is actually mandated by legislation in Texas, recognizing that maternal mortality was very high in the United States, but more so in the state of Texas. And so it became a legislation that was enacted. And through that, all licensed facilities in the state of Texas that provide maternity care had to be designated in order to receive Medicaid reimbursement. So not only is it important as we improve the quality of care for mothers and the neonates, but also for Medicaid reimbursement. So that is the document we have in place here. We at JPS have done, I'm not going to talk about all the initiatives for the sake of time, but happy to come back again if you'd like to hear more, that we have done a lot to improve the care of our moms. We provide a large volume of care. We did about 3,700 deliveries last year. We continue to be up on the increase in the number of deliveries we're doing for this year as well. Despite the fact that most of our moms are high risk, we have kept our C-section rates well below national benchmarks. Our quality metrics that are against Leapfrog and other national benchmarks are much below what the national norms are. And we also strive to provide care to moms and in those pregnancies that other facilities in the county are unable to provide. You know, a story that comes to my mind right now is a 14-year-old girl who has severe asthma, very bad narrow airway from a prior illness that she had in her childhood. And unfortunately, when she became pregnant, Cook Children's would not provide her further care for her ongoing medical condition. But we at JPS took her in. We have rallied together as a team from our anesthesiologist, ENT, and trauma surgeons and provided such phenomenal, high-level collaborative care to her that we are very confident that we can provide her a very safe pregnancy and a healthy neonate as well. So I think this is just a testament of how we have come around to deliver even very complex care to our very unusual patients here. And that's kind of what I have for you right now. And then again, you were talking about research grants. We're not only looking at just improving the routine care, but also trying to be leaders and thinking of how to redesign care to impact our most vulnerable moms who have more challenges than others in order to have healthy pregnancy outcomes. And we were very successful in getting the Essential Hospitals of America to recognize the work that we are doing in our communities and give us a grant to do some more work and looking into those communities. So that's what I have for you today. Our document was approved at our Medical Executive Committee on the 10th. Yes, today is the 12th. And so we're here to ask for your approval. I'm happy to take any questions.
Zim?
Entire nation. How do we stand here at the hospital as far as formula is concerned? And is there anything else that we in the other hospitals in the area could be doing to help these parents that are struggling to find formula?
So currently, we have not had any significant challenges within our moms here. Our hospital has a really strong group of lactation consultants who collaborate and have been able to provide that. We do a lot of donor milk here in the hospital per se, and that has not posed a significant challenge currently.
So is there anything we can do external to the hospital for these mothers that are having trouble getting formula?
We can definitely look into that as well. We'll work with our pediatrics team and a newborn nursery team who will be leading that challenge. I'll be happy to take back, and I can always come back. We can send you some responses.
I think maybe JPS, instead, I'm not just saying this is a JPS thing to go do, but we probably ought to look at other hospitals and see if we can't come up with something, because I think probably a lot of folks in here have had kids. And at that age, the one thing you want to make sure of is that they're not starving and that they're getting the right nutrients. And so if there's something that hospitals can come together, and at least if somebody says, I don't have any now, they know that they could come to one of the hospitals and get something while we bridge this gap, because right now it's going to be probably at least 2 months before we start to fill up the shelves again. And that's best case 2 months. So just a suggestion.
I think before we can do that, maybe we need to take a look at the inventory to see how many days on hand do we have first.
You have to go do that. I mean, you can't give away the store, but if we've got enough inventory, and to me, like I said, DT, if I can't feed my kid, it becomes a national emergency. To me, at my house, fortunately, my kids are gone, but I do know I've got friends that are getting new babies and whatnot, and they're struggling, not just here in Fort Worth, but all over. And if there's anything we can do to create a program that could, at least we become a court of last resort, that would be, I think, something beneficial to go do.
Yeah, I think that's a good idea, and then I'll ask Dr. Duncan to look at that. Reach out to Public Health, because they have WIC, and see if they can't pull together something for the community. I think it is an issue for the world, and so we should pull together our resources. And I know Public Health has some resources there, because they do the WIC program and have stuff with us, and so they'll go back and look at that. Am I correct, Doctor? Yeah.
The answer is yes. We will find out whether there's probably been some sort of collaborative group that's been brought together to address, I know, within communities themselves, that parents are sharing. Dr. Sangha makes a good point that we do have a large number of mothers who opt to breastfeed, And we do have the breast milk bank. That's also an option that we probably need to understand how much of that we have in the community too that can be used. And that's actually even better than formula for some of our newborns. But to your point, they are fed through a year. And so
I just think that if nothing else, we at least need to get it out that if in a dire emergency, we'll see what we can do to help you. But point well taken.
yeah, that's a great point. And we'll come back with kind of what is the work that's being done.
All right.
Thank you.
Thank you. Now, next we need the approval of the resolution approving the district maternal program plan. Okay. All right, it's been moved. Who?
Second.
I know Zim, you second. I didn't see Steve Montgomery. Okay. Are there any other?
He's been taking lessons from DT.
All right. If there being no further questions, all those approve of the resolution signify by saying aye. Aye. Those disapprove by nay. Motion passes unanimously. Thank you.
Thank you very much.
Madam Chair.
Thank you, Dr.
Madam Chair, this really has nothing to do with the vote we just took, but it has more to do with the story, and I know that we'll be looking for a new communications leader and team. We should have regular checkups with these departments to tell some of those stories, even if it's something written. Number one, it allows the doctors to unload the story, but two, give us as a system the ability to send that out every now and then, because they're really great stories that are out there. There's really bad ones, but there's really, really, really good ones, and we should make it a point to make sure that they're heard.
No, Roger, you make a great point. We have not told our stories out there. We've not told them to the board. We've not told them to the community. Actually, I was on part of a panel discussion yesterday in Precinct 2 with Commissioner Allen, and we had poll questions, and I purposely asked kind of, how much information, how much do you know about JPS? And it was really very little. So I knew that was the answer, but there is a lot of work to do, and I think now is our opportunity as we look for the next person to really do a lot of that community outreach and working alongside our foundation too, because they will also need to be at the table with that, but we have to tell our story, so good point.
Yeah, I certainly second what Roger said. We still suffer under the stigma of what we were back in the 60s and 70s. We need to work very hard with the new communications director to find a way to get our message out.
Yeah, once upon a time, yesterday, Reverend Emerson kept raising that issue, and leadership just would not listen. I just think there's too much great going on at JPS for us to always have to defend ourselves on negative stuff. Once upon a time.
Okay, back to the agenda. Now we're at the consent agenda. Are there any items that anyone need to remove from the consent agenda? Okay, then I will entertain a motion.
I need to abstain from finance, item B, and planning, item A.
Okay.
And for me, item B on the finance.
Okay. Y'all are abstaining from those, okay?
Mm-hmm.
All right.
I need to vote for all of them.
Okay, I appreciate that, me too. So let me get a motion here.
Move to approve.
Okay, Zim, Steve seconded for you. All right. All those in favor of approving the agenda as printed signify by saying aye. Aye. And those opposed by nay. And we will note the two that, the abstentions, okay? All right. Legal?
Madam Chair, I have a litigation update for closed session.
Okay, all right. Then we're at the point where we can close the open section and reconvene in closed session. And I'll give you 10 minutes, okay? Then that'll be 2:15. 2:15, that'll be 2:15.
Go. Always going to be.
session at 2:55. We have one item that we need to approve from the agenda, and that is the clinical privileges.
I would recommend approval of the privileges as submitted by Dr. Miles.
All right.
Second.
All right, we got that by Chuck, second by Zim and Steve. So all those in favor signify by saying aye.
Aye.
Those opposed by nay. All right. There being no further business, we are adjourned. We are adjourned.
I told you we could do